Hello, welcome today to Friday's clinical case. This clinical case today is going to center on my obturation technique, and I have changed my obturation technique over the years, and I make tiny little tweaks here and there, and I've made a small tweak quite recently on how I place my sealer within the canal while we're doing obturation. But of course, all of these Friday clinical cases showcase a full root canal from start to finish. And before we get into the case, what I want to say is, if you like this content, if you want to see clinical cases of live root canals done every week, please like and subscribe. Of course, there's a membership program where if you join our YouTube membership program, then you get access to early access to content. So let's get on with the case. So look at the radiograph here. This is of a lower right 6, and straight away what we can see is apical inflammation, specifically around the distal root of this lower right 6. We can see that the canals are quite sclerosed, and also we've got quite a large restoration in this tooth, and there is decay underneath this restoration. So obviously the patient was consulted, they've been told the diagnosis, they've been given all the options, and also they've been given the risks. And I suppose in specific to this case, my main risks are possibly restorability. Obviously we need to take the filling out and check the tooth restorable before we commence the root canal treatment. I'm concerned about the calcified or sclerosed nature of these canals as well, so the patient's being specifically warned about not being able to get to length. And also the tooth is, I feel like, is quite long. You know, it's really sometimes maybe irrelevant if the patient is made aware of that or not, but I think sometimes when a tooth is long, that can be more of a challenge to get to length. So these are all the things that you need to take into consideration. And of course, like I said before, what we've got to think about is restorability. So in the first instance, what I'm going to do here is I'm just going to remove these amalgam fillings, and essentially I just like to drill around the edges, and that undermines the filling, and this just kind of popped out nicely, and then some of the decay is removed. And we can see now that the cavity is all nice and clear, but that distal margin is very, very close to the gum line. And I'm going to use a sectional matrix here. Weirdly enough, in this practice, I use Paladent, but more and more often now I'm using more of a Garrison set. I feel like that's a better sectional matrices. But, you know, we work with what we've got in the practice that we work in. And, you know, I always like to place a wedge prior, and just to check to see if we've got a good margin. Here we've got a little bit of soft tissue which is trapped, and I'm just going to use a high energy ultrasonic just to remove this soft tissue. And sometimes this can just remove some of the sort of the soft tissue, and you can see now that there is a good tight margin between the matrices and the tooth. And now I am ready to etch and bond this cavity. You'll notice here what I haven't done is I haven't protected the canal spaces. I feel like, you know, in this case, it's such a large cavity that I can do that without placing PTFE over the canal spaces. And now I'm going to place a little bit of flowable in the base of this cavity, and the flowable just sort of goes into all the kind of little nooks and crannies of the margin. You don't want to place too much, of course, because its structural integrity isn't great, and I can see here that it's not really well adapted to the tooth, so I'm going to place a Paladent ring over this, and the adaptation's a little bit better. Although, like I said, with the Garrison, I feel like that adaptation's probably a little bit better. And then once we've set the flowable in the base of the cavity, we're just going to use some just normal bulk flow composite just to build up that wall. And I suppose it goes without saying, or maybe it's not obvious to some people, but it's really, really important to make sure that you put a good solid foundation into a tooth prior to commencing root canal treatment, and obviously there's a few reasons for that. The first reason, of course, is there's a possibility that you do the root canal and then found the tooth is unrestorable. And another reason for making sure that the cavity is good, and another reason to make sure that the cavity is good and solid, is because when you are doing the root canal treatment, I know I personally like to fill the cavity up with irrigant, and this creates like a nice kind of reservoir for irrigant to sort of flow into the canal spaces to obviously disinfect the canals, but also to to cool your instruments as they're sort of rotating in the canal space. And as you can see here, this is a really nice kind of restoration. It also it makes sure that when you are doing a restoration, that right at the end, you usually come into the end of the appointment, and what you don't want to do is you don't want to be messing around with all this. You want to just get this boxed off straight away, so when you finish the root canal, you've spent 2 hours, you're tired, you want to make sure that you can just fill the space up and then you're done. Okay, so making sure that you put a filling in a tooth and makes it solid has many different applications and reasons. So specifically with this tooth, I'm going to go straight for the mesiolingual canal. Don't ask me why. I usually go for the distal because it's easier, but in this case I feel like I just want to get down any canal, and I'm starting to negotiate down this mesiolingual canal with this size 10K file. And it transpires when I put the apex locator on this tooth, we're not quite at the 0 reading on the apex locator. So what we don't want to do, we don't want to push this file any further. We're just going to mark the stopper, we're going to take the file out, and then we're going to just measure how far we've got, and in this case it's 23 millimeters. We're then going to take our 1503 high flex glide path file, measure it 23, and then we are going to try and shape out the canal that's been successfully negotiated. We're going to open up this kind of canal space, and usually when you can't get down a canal space, it's because the file is getting gripped further up its shank rather than at the tip. And then I'm going to use a size 25 variable taper, so a thicker file, minus 1 millimeters away from the furthest point we've reached. And I'm going to really open up that canal space. So we're going to go back in with our size 10K file down the mesiolingual. We're going to do a little bit of watch winding, very nice movements, not trying to push the file too far, because obviously you're gonna ledge this tooth, and you can feel now that it's going a little bit further. And when we place our apex locator onto this file, we can feel now that we're going to get a nice 0 reading, and then when we pull this K file out and we measure it, we can see that the 0 reading in the mesiolingual canal is at 24 millimeters. So we're ready to shape this mesiolingual canal, and the first thing we're going to do is we're going to use our glide path file, the 1503, and shape this to 0. So we're going to measure this file at 24, and then we're going to shape it nicely to the 0 reading in the apex locator. We're then going to take a 2004 high flex file, and then we're going to shape it minus 0.5 millimeters from the working length. And the reason why I've not gone from a 15 to 25, which I usually do in most cases, is because it's quite sclerosed, this canal, and I feel like I need to make a kind of a less of a jump or a less of a step up to make sure that I don't ledge the tooth or fracture a file at all. And then I'm going to recapitulate again. Rightly or wrongly, I don't recapitulate with every single canal, but again, I'm really mindful of the sclerosed or calcified nature of this canal. Essentially what recapitulation does in this case is it just makes sure that the canal space is still open, okay, so there's no debris down there, and you're just making sure that the canal is still patent, ready for your next rotary file. It's obviously going to be a higher diameter. In this case, it's going to be a size 25 variable taper high flex file, and this is going to be again shaped minus 0.5 millimeters away from the 0 reading on the apex locator. And there you have it, mesiolingual, done and dusted. We're then going to try and get down the mesiobuccal canal, and you can see here that I'm struggling a little bit. I always feel like the mesiobuccal canal is usually the canal that the patient has to open really wide for you, because it's just always a little bit difficult to sort of squeeze the file in there. But eventually I get it in, and then I'm just going to do that nice kind of watch winding motion with the size 10K file. We place the apex locator on this file, and we find that again we're not getting that 0 reading, and obviously I'm going to just place the rubber stopper to as far as we can get, pull the file out. We then measure how far we've got. In this case it's 20.5, and then we're going to just do the same protocol as before. We're going to use higher diameter files, But unlike before, I'm going to use this orifice opener because I feel like the mesobuccal orifice is quite narrow. You know, I could use a size 25 variable taper high flex file just to open this up, but what I'm concerned about is going a little bit too far with this and ledging the tooth. So in this case, I'm just going to use the orifice opener because it's very, very short, so there's no kind of chance of this really, really thick diameter file cutting a ledge or anything like that. Once we've done the orifice opener, we're going to use a 1503 high flex glide path file, and we're going to obviously shape this up to the point where we have got with our hand file. And again, we're going to use the size 25 variable 0.5 millimeters away from as far as we can get, and then we do a nice little bit more irrigation. Always irrigate, it's really, really important. And then we're going to just place our size 10K file, and unlike last time, it's still not getting to 0, okay? And I can kind of feel like maybe this hand file is progressing a little bit more, but not well, it's not getting 0 on the apex locator. So we place the stopper on as far as we've got, and then as we pull the hand file out, we can see that it's only progressed about a millimeter, so now it's got to 23. So I'm going to use a size 8D finder in this case, and as I use this 8D finder, I've made a tiny little bend at the end, not too acute, and then I'm just using a kind of gentle watch winding motion just to try and feel around for that sort of patency in the canal. And as I gently push this D finder to length, we're going to get that lovely kind of drop into the canal, and then we're going to put our apex locator on, and now we're getting 0. And obviously it's important to know that the 8D finder is probably a little bit too small for us to gain an accurate working length. It's always a good kind of baseline measurement, a kind of an accurate sort of roundabout measurement to know where we're going with our hand files and our rotary files before we take the proper working length. And it's always important that when you drop past that point where you couldn't get past previously, is not to pull a file straight out. It's just to do a little bit more shaping, making sure that part of the bit that you got that was difficult for you is still painted. And when we measure it, we're about just over 23, so we weren't too far off with our other hand files, but it's really, really important obviously just to be really, really careful and take our time. And then once we've reached 0 with our size 8, we're going to go in with our size 10K file, because we're not going to go straight for our glide path files. We want to make sure that the jump from an 8 to a 15 is quite significant, and we're going to make sure we get to our 0 reading with a size 10 and shape it out and keep it painted. And then it's the same protocol with the MB, lots of recapitulation, size 1503 high flex, size 2004 high flex, and 25 variable high flex. And then that's it, 2 canals nicely shaped, and now we're ready to go onto our distal canal. And we know that there are 2 canal orifices in this tooth, and I feel like I'm having a little feel down both these canal orifices, and I can get down the DB canal quite easily. And obviously there was no mucking around, we just used the same protocol again, 15, 20, 25. And then once we've finished our shaping of this DB canal, we'll call it DB canal because really it's the same canal, we can see that there are 2 orifices, but they join, okay? So in a way, some people might say that this is a ribbon-shaped canal, or these are 2 different orifices. It's irrelevant really, but you can see here when we aspirate and when we irrigate the canal, both these 2 orifices are irrigating and aspirating together. So what I want to do is I want to work out at which point do these 2 orifices join together. So I'm going to place my GP point in the distal buccal canal to length, and then I'm going to place a size 10K file, can be any file really, in the contralateral orifice, and then I'm going to mark the GP point through this other orifice with this hand file, and then I'm going to pull the GP out, and then I'm going to inspect the end. And then when we look at the end of this GP point, we can see that it's marked the GP point right at the tip, okay? And obviously what we do is we measure the rubber bung on the hand file to see where this is marked to the GP point, and then we're going to shape up to this point, because what you don't want to do is you're going to use your rotary files and not going to want to move around this sort of tight bend in this joint, because the other part of the canal has been shaped successfully. So why make any more work for yourself, and it's safer as well. So make sure that you're only shaping up to this point where the two canals join. And again, it's the same sort of protocol. We're going to use our size 20 this time, because we know this canal's quite open. We don't need a glide path file. And then we use our 25, and then all 4 canals are shaped, 3 or 4 depending on how you see it. And now we're ready for our cone foot radiograph. So this is kind of our, like what I say to patients, this is our kind of dress rehearsal for the root canal. This is where we place our GP cones to the point where we're going to fit them with sealer. So obviously what I do every single time is I make a note of the length, the working length of the canal that we're working with, and then I measure the GP point, and I use interlocking tweezers to snip to this point, and then I push the GP down to the length, and then I see at what point the cone's been sort of crimped at, to see if that corresponds with the correct working length. And in this case, we look at the cone foot radiograph, and it looks really, really, really nice. So this is really, really nice. Although some endodontists might kind of balk at this type of obturation, and what's in vogue at the moment is our small preps, okay? And I suppose this is the problem essentially with high flexes. The taper is relatively large. I think personally there is a place for narrow preps, and there is a place for super large preps. Now, I don't think the high flex is an aggressive file, but people would probably, people might disagree with that. I think the problem with doing narrow preps is it can be quite difficult then to obturate successfully. So it's basically just a fine balance, and you obviously obturate to a point where you are comfortable with, because what's more important is that you do a treatment that is predictable in your hands, rather than a treatment which is probably predictable in somebody else's hands, if that makes any sense. And then we're ready for the obturation. And again, this is essentially what the video is about, is my obturation protocol. And basically what I need to do now is I need to disinfect these GP points. So what I am going to do is I'm going to remove these GP points, and then I am going to put them in a GP disinfector. So you can use whatever you like. You can use Dappens pots, you can use paper cups or whatever. But if we look at my Style Italiano GP disinfector, this is a really, really useful tool, because it is autoclavable. And then it has like kind of wells in the disinfector where you can place your GP points, and then you can fill this up with hypochlorite. And this serves as a few purposes, okay? Because obviously you want to disinfect the GP points with sodium hypochlorite, because the GP points, most GP points, are just in a little tiny box, so they're not disinfected. And obviously you've just disinfected the root canal space full of you got rid of all that bacteria, and you don't want to then place, theoretically GP that has bacteria on it. It also has a nice little dry area as well, and what I mean by a dry area is in the middle. My nurse likes to place kind of paper points in this place. And also it serves as a kind of a well for my EDTA to be placed in as well. So it kind of, it's like an all-encompassing area for me and my nurse to kind of gravitate to. And she knows where to put things, and she knows where to put the EDTA, and I know where to suck things up. And it just basically makes the obturation part of the root canal just really, really efficient and easy. And obviously, as if you've got a new nurse, you can just tell her this is the kind of obturation area, if that makes any sense. So prior to obturation, I'm going to do my irrigation protocol. Sodium hypochlorite activated, EDTA 17%, activated, and then a final rinse of sodium hypochlorite, and this is activated. And once we have cleaned everything out, I'm just going to aspirate my my sodium hypochlorite, and then I'm ready to dry with paper points. And you can see here now the nurse is setting up the sort of paper points, and basically I'm just going to take the paper point from that area, from this little disinfector, and then I'm just going to place it to length. And once I place the paper point to length, I'm just going to pull it out and have a just inspect to the end just to see how wet it is. And I'm just going to continue this drying of the canal spaces until it's completely dry. And then, as you can see here, my nurse is just placing more and more paper points until I say to her, you know, I'm getting to the end now, I don't need any more. And this is great because obviously you're not physically going into the bit where the paper points are, so it's also from a disinfection point of view, it's like a separate area that the yawn nurse, she knows that she can place things down there, and then obviously she's clean and I'm dirty, shall we say. And once we've used all our paper points and all the canals are dry, ready for our obturation, I'm going to use one fill here. This is a bioceramic sealer, and I'm going to use these visco tips. And then before I do any obturation with any canal, I get everything set up. I'm going to make sure my visco tip is loaded with bioceramic sealer, and then what I use is a pair of tweezers to pick this GP point out, and then I place the tweezers onto a paper point, not the GP itself, but just the tweezers. And what happens is the kind of the water retention from the tweezers kind of sucks all of the liquid away from the GP point. I'm then going to place the locked tweezers with the relevant GP point onto the disinfector that's ready to go into the canal, and then I move over to the canal, and then I'm just going to load the canal with my bioceramic sealer, and I'm going to maybe fill it maybe a third of the way in the coronal third. And then now what I do is I like to introduce a hand file into the canal. I never used to do this, but I feel like this gets rid of any kind of vapor lock, and it also introduces the sealer into the whole full length of the canal space. We're then going to pick up our locking tweezers with the GP point, and then we're just going to very, very slowly and gently push this GP to length. We're not going to ram it down because obviously there's a risk of extrusion and also vapor lock, which is going to be very, very, very gentle. The high flex GP cones are quite thick, so there's a real significant risk of vapor lock. And then we just cut off the excess. Obviously I'm not going to use this heated plugger far down into the canal space, and once we've removed the excess, I'm then going to use a Mach 2 plugger just to condense this GP cone really down nice to length. And you can see here that the mesial buccal and the mesiolingual are convalescent because you can see the sealer in the two canals. And then it's the same protocol. I'm just going to pick up the GP point, crimp it down, just remove the excess, place it to the side, ready to go, and then we're going to place our bioceramic sealer into the mesiolingual canal, and then obviously just place the GP cone to length, very, very, very gently. And it's just the same thing, just nice, easy movement, very gentle. Don't push it down. Take your time. And you know, we look at the radiograph, and you know, it's just beautiful. It looks fantastic. You know, granted, we've got a bit of sealer puff on the distal canal. You know, a lot of people don't like a sealer puff. I am in the mind that I don't want to create a sealer puff, but if it happens, it's not the end of the world. I feel like the sealer puff actually has kind of mushroomed around the sort of distal apices. So, you know, there's a possibility that there was just a high complexity around the end of this tooth. So, you know, you could argue that this is sealed off the end of the tooth quite well. And overall, again, a really, 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 really nice result. I'm super, super happy with this. And there you have it. Listen, if you have any questions today, if you don't understand anything, please comment in the section below. If you have any criticisms, again, really, really important. If you disagree with anything, put it in the comment section below. This is the whole point of the channel, is to encourage learning and discussion. And I try and answer any of your questions as quick as possible. And like I said at the start, if you have any, if you really, really like this channel, please like and subscribe. We've got a membership program. The membership program is run by YouTube. You pay a certain amount, a tiny amount per month, and what you get is you get to support the channel, keeps me independent, and also you get early access to content. And I will see you in the next video. Bye bye.